My name is Eliza Buyers, and I am coming to you from Denver, Colorado. I apologize that I can't be there live today, but I had a conflict that I could not rearrange. So it's great to see you all, and I hope this is a good session for many of you. Let me get my slides up. All right. So I am a pediatric and adolescent gynecologist at Children's Hospital Colorado. I don't work in our RET or CDKL5 clinic, but we do have a center for excellence, and I see a lot of patients and families from that clinic. And I also see, kids from all aspects of our hospital for gynecologic consultation. So I hope today that we will get through some information that's valuable to you and your kids. So outline for today, first we're just going to talk briefly about adolescence, about puberty, kind of like the what and why. And then we're going to focus on my area of real expertise, which is menstrual periods, why they happen, and then certainly options to manage if they are problematic. Cool. So adolescent development. I just really want to start with challenging any negative, lots of negative feelings out there about teenagers and adolescents. And I really think it's not helpful. It's actually an incredible time of development. If you think about, even for yourself, the changes that you went through between age 10 and age 25, which is really, some people define the end of adolescence as even later than 25. And certainly we focus a lot on the physical changes, but there are so many aspects to adolescence: cognitive, emotional, behavioral, social. And I see kids who don't go through the physical changes because of medical issues, and they still go through adolescence. And so just understanding how comprehensive this is. Also, how natural and healthy and essential adolescence is to the process of being a human. And then the other thing to know is that changes are not synchronous. Physical changes do not tell you where someone is emotionally. There is a lot of back and forth. So just to be aware that this is a really, really cool time, but that also it's just really exciting. So that's how I think of it, and I encourage everyone to think of it that way. This is not new. This was a headline from National Geographic in 2011. But at the time, it was very exciting for me because I kind of felt like popular culture and science was catching up with what we know, people that work with teens know, is that the brain of teenagers is incredible. So we used to think, oh, the brain, oh, there's a typo there. That's supposed to say 90%. The brain is 90% of adult size by age 6. And we used to think, oh, it must be done growing. But it turns out that's not true at all. There is lots of growth and rewiring and remodeling happening over this time period, lots of different areas. Really the whole brain, certainly the prefrontal cortex and the corpus callosum, but really the whole brain. And so the potential there for change and learning and new pathways is incredible. Now there's also, of course, potential for rage and alienation and just frankly being overwhelmed. But just something to think about as we get more into the physical changes now. So, I don't have a perfect resource for you in terms of talking to your kids about sex and puberty. I don't think anyone does. Definitely there are some best practices, and if you have a very young kid, the time to start with this is right out of the gate. Little babies, you can talk to them about what you're doing, and you can use correct terms for body parts. That is pretty important. It's really hard for kids who do need caregiver help with private areas, but as much as possible, talking about, what is appropriate and what's not, and why certain touch is needed to help maybe stay clean or to help with bathroom, but then other touches would not be. And really letting kids know that what's happening to their bodies is normal and healthy. The fact that their bodies are changing, that's a really good sign that they are healthy and getting the energy that they need. These are a couple of my favorite books. They are not specific to kids with developmental disabilities. However, I think that parents are pretty good at tailoring things to their family and what's appropriate for their family. And that's another website, Amaze, which is really designed for preteens. In terms of education, sexual education resources for people with disabilities. This is a great resource, Respectability. Most of the materials are focused, there's some focus work for people with autism, some focus work for people with Down syndrome. And I do think there are some resources there that are really helpful for all people. Really all people, the basics of communication and respect and honesty really cross kind of all boundaries. So there are some resources if you're interested in that. In terms of the actual physical process of puberty, it starts in the brain. It starts in the hypothalamus. The hypothalamus makes GnRH. GnRH is present, but the pulsatility changes. And with this change in pulsatility, that stimulates the pituitary to produce LH and FSH. And these are hormones that act on what we call the gonads. So in people who have ovaries, the ovaries are stimulated to make primarily estrogen, which then leads to secondary sexual characteristics that we'll talk about in a second. For people with testes, the testes are stimulated to make testosterone, and then secondary sexual characteristics follow. So again, puberty is a process that starts in the brain. Now, timing of events is interesting to note. And kids with complex medical issues sometimes read the textbook on this and sometimes don't, as you all know. But in general, I would say being aware of the norms is good. So for girls, the onset of puberty, the first thing that will be noted is the breast bud. And that is due to estrogen effect on the breast. And it's just very easy to note that the breast will go from being completely flat to developing like a bud behind the nipple. It can start on one side, it can be tender, and then it will develop to both. And then over the next 2 to 3 years, the breast will grow. And you can see these numbers here, 2, 3, 4, 5. Those refer to Tanner staging. Almost all people, when they get their period, their breast is about Tanner 4. So really, from the moment you see breast bud, that's a good thing to note because the period will be coming in the next 2 to 3 years. So the average age of what we call telarchy or breast budding is around 10. However, it can be as early as 7 and as late as 13. The average age of getting a period is 12 and a half, but again, that can range from 10 to 15, depending. It's really the timing when breast budding is starting, then a period should happen 3 years later. Couple other things to note. Estrogen in the beginning at low doses stimulates the long bones to grow. In much higher doses, like reproductive age doses when someone gets their period, there's usually not a lot more linear growth of the bones after that point. A couple other things to note is I apologize. I am getting a phone call. I'm so sorry. A couple other things to note. Pubic hair is actually controlled by the adrenal glands. When they turn on, it's something called pubarchy. It sounds a lot like puberty. For most girls, that happens after breast development, but there are some kids who do that earlier. Just because someone has pubic hair and armpit hair does not necessarily mean, it does not start the clock for getting your period. The breast bud is really the hallmark for if estrogen is being produced or not. And these are good things to check in with your pediatrician about. We used to think of weight, in itself. You had to be 100 pounds to get your period, but really that is not at all true. I do not find that in my population of kids with special needs who tend to weigh a lot less. It's really more about, is nutritional status, is energy needs adequate? And in kids who are maybe very, 60 pounds, 70 pounds, as long as their energy needs are being met, this is a process that takes off. So how do periods happen and why? So the estrogen, in addition to affecting the breast, it starts to affect the uterus. The uterus starts to grow. The lining of the uterus, what we call the endometrium, thickens in the presence of estrogen. And that first period happens when the lining gets thick enough that some of it sheds. Now, there's also another way to have periods. So you can have a period just because the lining gets thick enough and bleeds, or you can have a period because of ovulation. And ovulation is where the ovaries make an egg or an ova. The corpus luteum, where that egg comes from, makes progesterone for 10 days. And if a pregnancy doesn't occur, then the progesterone drops, the estrogen drops, and there is a withdrawal bleed. So there are ovulatory periods and there are anovulatory periods. In the first 6 to 8 years of getting your period, many of your cycles are anovulatory. So there's kind of a paradox here where lots of the periods in the first, definitely in the first year, but even in the next 6 to 8 years can be kind of weird and light and then heavier. That said, once someone has a period, they should have one at least every 3 months. You shouldn't go longer than 3 months without a period. That'd be a good time to check in with your doctor. You shouldn't bleed more often than every 3 weeks. You can only ovulate every 3 weeks. So if you're having bleeding every 2 weeks, something's up. And then the period itself should last no longer than 7 to 8 days. And so, so I always tell people between every 3 weeks and 3 months, and about 7 days long. As long as we're in that time frame, we're having fairly regular cycles. So why are some of the reasons that people come to see me? Well, definitely, I think, the kind of anxiety about adolescence and puberty is a lot. One thing that I didn't say before, which is I wanted to say, is that I do not think it's helpful to kind of blame things on puberty and adolescence and just leave it at that. If your kid is struggling, if you are struggling, if siblings are struggling, get the help you need. Just blaming it on becoming a teenager is not helpful, and also just not true. If there are issues, get help, get them addressed. I think really the definition of being a parent is you think you have everything figured out, and then the next day you don't have anything figured out. So I'm very empathetic about that. So the reasons that people come to see me, here I have them listed. Hygiene concerns are a huge one, right? Just like yet another burden. Sometimes, we're in pull-ups anyway, what's the big deal? But that's often just not the case. It's another thing to deal with. A lot of irritability, pain, obviously, if kids have GI pain, and then on top of that, they have cramping pain, what is what? Seizures. Seizures are incredibly complex, as you know. Any changes in sleep, weather, eating, illness, will affect seizures. And certainly for some hormonal changes, those changes in estrogen and progesterone can really trigger seizures. For some, not. Any medical problem can get worse on a period, whether that's headaches or back pain or anything. And then certainly, awareness that when someone is having a period, they are fertile. And so having contraception on board to prevent pregnancy for some people is an important aspect of this too. What we find is for our families and patients, it is many factors. It's not just one. I mean, sometimes it's just one, but usually it's many considerations. So if we're thinking about menstrual periods and how we might be able to stop them, how does that work? Is that safe? And the answer is yes, it is absolutely safe. So, we have ingrained in us that we have to have a period every month to flush things out. Well, that is true when you're not on hormonal therapy. Okay, so when you're not on hormonal therapy, the lining of the uterus is getting thicker and thicker and thicker. And if you don't have a period, that's not good. You're either pregnant or that lining is building up in an abnormal way. However, when you're on hormonal therapy, all hormonal therapy contains progestin. Progestin is a synthetic version of progesterone. And in the presence of low dose progestin, the lining does not build up. So it is safe not to have periods. The other thing that happens in the presence of progestin, when there is adequate progestin in the bloodstream, is that the brain does not tell the ovary to ovulate. And so there's also suppression of ovulation. Now we're going to talk about all the methods, and we're going to talk about how the IUD works more locally, but all the other methods also suppress ovulation. So here are available options for hormonal therapy. This doesn't include every single type of pill, but it includes most of them. All of them contain progestin. Progestin is safe for everyone. So progestin does not increase the risk of blood clots. Progestin really is safe for people with high blood pressure, low blood pressure. Where the real contraindications come in is those methods that contain estrogen, and that's the pill patch ring, and we'll talk about that in a second. There is no best option. The best one is the one that makes sense for the individual that I'm seeing, for their family. Certainly, there are going to be preferences, and that is completely okay. So thinking about the options, and if you're, if a patient's with me and whether they're interested in menstrual suppression now or they just want to know about it, we just kind of go through the options. There's a little bit of bias in that a lot of the patients that we see are interested in a levonorgestrel IUD. They're coming to us for that. If they were just interested in a pill, maybe, they would get that from their primary care doctor. Not always, but about half the patients that come to see us do decide to get a levonorgestrel IUD. In this case, this is placed under anesthesia. We commonly coordinate with, say, a dental procedure or a sedated MRI. And while the patient is asleep, we place a speculum in the vagina and place the IUD into the uterus. Now, once someone is having regular menstrual periods, their uterus is adult size. So there is no role for pre-screening for, to see if the uterus is big enough or anything like that. The IUD works locally to release progesterone so the lining doesn't build up. It is a approved treatment for heavy bleeding. It is approved treatment for pelvic pain. So many of my patients, their mothers or sisters have had amazing results with the IUD. Among OBGYN doctors, such as myself, this is the most commonly used form of birth control, but also a way to manage problem periods. The Mirena, when it was introduced, it was FDA approved for 5 years. It's now, we've known it's effective for 7, but it actually got changed, the labeling. And I just saw another recent study that it's effective for 8 years. So we're talking about replacing at 7 years. Now, the one thing to know about, there's a couple other nuances about the Mirena or the Liletta, which are the progestin IUDs. They work locally. They don't suppress bleeding entirely in all people. So about 50% really will be suppressed, no bleeding. Other 50% will have periods, but very, very light. We sometimes add an additional medicine, though, for people who don't want to have bleeding at all. And then the other thing to note is that because of the local effect of the progestin, some people don't ovulate with the IUD, so the brain senses the progestin and does not tell the ovary to ovulate, but some people do and are ovulating every month. It's just that they don't bleed because the lining hasn't built up. So for some patients where, they really want to keep the hormones steady because of seizures or because of another concern, we may not go to the IUD right away, or we'll go to the IUD, but we'll recognize that there may be a need for an additional hormonal therapy if we are still noticing kind of like monthly dips. And you're going to see lots of images from our website. This is cupag.org is our website, and this is a handout for patients on having an IUD placed under anesthesia, if that's something that you want to read about. One of the other really common medications that we use is something called norethindrone acetate. The brand name of this medicine is Agestin. And because it does not contain estrogen, it is considered safe in almost everyone. And we're going to talk a little bit more about estrogen. It is very well tolerated. It crushes very well. It can go into a G-tube very well. It is actually FDA approved to treat endometriosis. So endometriosis is where the lining of the uterus gets outside the uterus and causes havoc, pain. This progestin causes that lining to atrophy and shrink. And so it works really, really well for suppressing bleeding. Sometimes getting out of the gate, there can be lots of little breakthrough bleeding where we have to keep doing 4-day breaks. But, 3 to 6 months out, most people who take this every day do not have any bleeding, and you don't have to do a break unless you have what's called breakthrough bleeding, and then you do a 4-day break and start again. It is not an approved contraception. It just hasn't been studied in that way. So that, again, usually not a big concern for my special needs population, but, it is not labeled as a birth control. And so if that is important, that may not be the best choice. There is something called the mini pill. Maybe it's something that moms have taken when they're breastfeeding. It's a progesterone only birth control pill. You can see the dose is only 0.35. This is 5 milligrams. So norethindrone acetate Agestin is not the progesterone only mini pill. And so if you're talking to your doctor about that, make sure you're getting the right one. This mini pill can work in some people, but about 50% of people have breakthrough bleeding. So we don't see as much success with it. Combined hormonal contraception. This is the combined birth control pill. I'm gonna move my face because I'm wondering if I'm blocking. This is the combined birth control pill. This is the birth control patch. There is a birth control ring. Again, not something usually that patients with developmental disability are interested in, but certainly the patch and the pill. And these can be used to have a period every month. They can also be used in extended and continuous dosing, just like the norethindrone acetate, so that periods are never or just, seasonally every 3 to 4 months. Estrogen is contraindicated in folks who have an increased risk of blood clot and stroke. Now, for people who are, let's say, living in a wheelchair most of the time, that is actually, if they have been doing that their whole life, that is not considered a independent risk factor. For someone who has been ambulating and then would be not ambulating, that would be an increased risk for blood clot stroke. So, just there have to be other reasons why we wouldn't use estrogen. And these are very popular methods. The other nice thing about the methods with estrogen in them is they improve acne. Hirsutism is extra hair on the face in male pattern areas, but acne, which can be very difficult, especially if kids are picking or just don't like the way it looks. So the pill and patch really, really help with acne too. So that might be a reason why this option is considered over others. The progestin only options that we've talked about don't have a positive effect on acne. They don't necessarily make it worse, but they're not going to make it better. This is from our website. So if you are wondering, well, how can you do the pills so you don't have a period every month? You make sure your doctor prescribes it in the right way. Make sure you're getting 4 packs for 3 months, not 3 packs for 3 months, because you'll run out. And then you only take actives. This doesn't necessarily work right out of the gate. You may start to bleed in here. You do a 4-day break and then you restart. If it's taken the same time every day, most people can get to really good suppression with this. Depo-Provera, which many of you may have used or been aware of, was extremely popular about 25 years ago. But we have other long-acting methods now which have fewer side effects. Depo is an injection you get every 3 months. It only contains progestin, so it's safe for most people. Not everyone stops bleeding, but within 6 to 9 months, most people are no longer having any menstrual bleeding. It's also a treatment for endometriosis, so it's very good for pain. But it really has fallen out of favor for menstrual suppression in the setting of developmental disabilities, especially in someone who is not weight bearing. The Depo likely decreases estrogen levels overall, and estrogen is what is responsible for increased bone density in girls. And so the concern is in people who are not weight bearing, in people who are maybe on seizure medicines, which also affect bone density, Depo is not necessarily the best option. Now, some of my families have had incredible maybe seizure control or other awesome responses with Depo. So it is really weighing risks and benefits, but I can tell you there are also people in the rec community, for example, who say Depo should never be used. I don't think it's that black and white, but we're not using it as much because we have other options. The other thing about Depo is I really feel like it's nice to be really responsive when you start something and it's not working. And if you give a Depo injection, you are stuck with it for 3 months, maybe longer, because it takes a while to wear off. There is a home dosing option, so you can come in the office. There's an IM version, but there's also a sub-Q option, which families and patients can pick up and give an injection to themselves. So good to know about. The Nexplanon or Implanon is a little rod that goes under the skin in the arm. It is an amazing birth control option. However, if I put 4 implants in, only 1 out of 4 patients will not have her period. So the implant is, you should expect to have irregular bleeding when you have the Nexplanon. It doesn't necessarily get better, it doesn't get worse. And like I said, it stops ovulation. It's a fabulous method for contraception. We do not see pregnancies with it. Someone gives me their arm, I numb up the arm and insert it. It takes about 30 seconds to put in. However, when the goal is menstrual suppression, no bleeding, and there's only a 1 in 4 chance of that, it's usually not our first choice. However, it is a safe thing to try, and I definitely have talked to lots of families where it has worked really well. Insertion and removal is quite easy. Most kids will allow me to do that. Obviously, not all kids who don't like being touched, but it's a pretty easy insertion removal. So side effects. So I am very humble about side effects. People know their bodies and know their kiddos' bodies much better than me. I can reassure you that overall, all of these methods are very well tolerated. And when you do blinded studies where, let's say, you give 100 people the birth control pill and 100 people something that looks like the birth control pill and isn't, we see very similar rates of things like mood changes. We don't see weight gain in birth control pill users any different than the control group. These methods are very, very well tolerated. However, of course, there are individual differences, and there's so much going on in our lives, and it's very hard to figure out, okay, well, is it this new medicine or is it something else? Is it something that would have happened anyway? So being aware that something could be a side effect or could not be a side effect and figuring out how to manage it. definitely the most common side effect for all is breakthrough bleeding, which means you started this medicine so you wouldn't get a period, and now you're bleeding all the time. And again, making sure you understand, is this the kind of thing that is expected? For example, when a Mirena IUD is placed, there can be this kind of breakthrough bleeding for the first 3 to 6 months, usually resolves. With continuous birth control pills, usually you'll often have these breakthrough bleeding events. You should do a break and restart, but there can be a lot of those in the first 3 to 6 months. If it's an oral pill, you all are usually very good at taking medication the same time every day, especially if there's seizure medication, but that can be very, very important. And then I just, being willing to try another option if the first one doesn't work out. If there is a concern that something is causing something, like let's say a mood issue or a behavior issue or more irritability, is it possible to do a break for 2 to 3 weeks and see if that behavior goes away? And then of course, trying another option, we already said that. Treatments to avoid. So I do get requests for a couple treatments that we should not, are not best practice and not supported for various reasons. So, we should not be suppressing periods before the first period. Just like all people, other issues can be going on, and having that first period really tells us that the brain and the pituitary gland and the ovary and the vagina, that is all working. So having at least 1 day of menstrual bleeding, I will talk to families and we will make a plan. Maybe we'll even send in a prescription, but that should not be started until there has been at least the start of a period. We don't need to have many periods. That is not true. I think historically there was this myth that, oh, you have to wait a year of periods before you can suppress them. That's not true at all. But we want to at least make sure that the systems are all go before we start medication to stop them. There is a treatment called endometrial ablation, and that's where the lining of the uterus is burned. That is very likely to fail and regrow if it is done before the age of 40. So ablations should not be done in any people before the age of 40 due to failure. It is also not a form of birth control, so you still need some kind of birth control on board if you're doing an ablation. A Mirena IUD is as effective at ablation in terms of suppressing periods. And once you have an ablation, you can't do anything. Your next step is hysterectomy if you fail. Having a tubal ligation is really not appropriate. Tubal ligations fail actually at rates higher than implants and IUDs. And so if the desire is for birth control, we have better options. It's also to be important to be aware that there is a long history of forced sterilization in our country, and there are huge ethical issues. Removing the uterus and or ovaries should absolutely not be done unless there are gynecologic indications. So some of our patients do have gynecologic concerns where removal is an option, but just to remove things so that they're not there is not appropriate because there are so many other options to deal with whatever the concern is, whether that's bleeding, whether that's cramping, whether that's the need for birth control, etc. So good things to know there. Again, this is what our website looks like if you want to shop those methods or learn more about them. And here are some resources for providers. So of course, I would love it if every person got to see, I saw everyone, or we had a pediatric and adolescent gynecologist see everyone, but that's really usually not necessary. There are well-defined, developed, this is a committee opinion from the American College of OBGYN. So this really goes through the options, how it is safe, what the options are, and then This is actually a video from our hospital. I think it is 7 minutes long, and my hospital does these provider education videos. So this is basically the same content we just went through, but focused to primary care providers and other providers, and so that they can provide these medications for menstrual suppression. And I tell my patients, listen, I am here, but my job is to really get you guys going on an option that works. And I hope that your primary care provider will take over this prescription, or you'll just come back and see me when a change is needed. That is all I have to share with you all today. This is my wonderful team at Children's Hospital Colorado. These are my fellow pediatric adolescent gynecologists. And I hope you have a wonderful conference. Thank you so much.